Meconium Aspiration Syndrome occurs when a newborn inhales meconium-stained amniotic fluid, typically in the setting of perinatal stress. Clinically, this manifests as respiratory distress immediately at birth or within the first few hours, ranging from mild tachypnea to severe hypoxemia with persistent pulmonary hypertension. The incidence of meconium-stained amniotic fluid increases with gestational age, occurring in about 10 to 20% of deliveries, but only a subset, approximately 2 to 10%, develop MAS. In high-resource settings, this equates to roughly 0.1 to 0.4% of all live births. The spectrum of disease is broad, which underscores the importance of early recognition. Mild cases may show transient tachypnea and require only supportive oxygen, whereas severe cases rapidly progress to hypoxemia, hypercapnia, and possible right-to-left shunting through fetal channels. Recognizing MAS early is critical for guiding immediate resuscitation strategies and anticipating the need for respiratory support in the NICU. Meconium is composed of water, bile salts, and pigments, desquamated epithelial cells, vernix, mucin, and residual amniotic fluid. Each component contributes to its density and chemical activity, with bile pigments and mucin increasing viscosity and the epithelial cells adding particulate matter. Its physical properties, thick, viscous, and sticky, make it prone to lodging in small airways. This mechanical obstruction impedes airflow, creating regions of atelectasis and air trapping, which increases the work of breathing for the newborn. Meconium also acts as an irritant to the pulmonary epithelium. Contact triggers an inflammatory response, causing edema, surfactant inactivation, and further reducing lung compliance. Clinically, this is significant because meconium may be aspirated before or during delivery. Aspiration can occur with fetal gasping or during the first breaths, placing infants at immediate risk for hypoxemia, hypercapnia, and in severe cases, persistent pulmonary hypertension. Recognizing these properties explains why even small amounts of meconium can lead to significant respiratory compromise. Meconium passage is a physiologic process that reflects both fetal maturity and intrauterine stress. As the fetus reaches term, the enteric nervous system matures, peristalsis becomes more coordinated, and the intestinal contents accumulate, including desquamated epithelial cells, bile pigments, and mucin. This maturation alone increases the likelihood of meconium being present in the intestines prior to labor. Superimposed on maturity is fetal stress. Episodes of hypoxia, from cord compression, placental insufficiency, or intrauterine infection, activate the parasympathetic nervous system via the vagus nerve. Increased vagal tone has two effects. It relaxes the internal anal sphincter and simultaneously stimulates colonic peristalsis. The result is meconium being propelled into the amniotic fluid. Timing matters. Meconium expelled late in gestation or during labor coincides with fetal gasping movements. These gasps create negative intrathoracic pressure, which can draw meconium into the upper and lower airways even before the first effective breath. The slide emphasizes that the combination of fetal maturity, stress-induced vagal stimulation, and gasping creates the substrate for aspiration and sets the stage for MAS. After meconium is expelled into the amniotic fluid, aspiration can occur in two primary ways. First, in utero, aspiration happens when fetal hypoxia triggers gasping movements. These gasps generate negative intrathoracic pressure, pulling meconium-stained fluid into the larynx and trachea, sometimes reaching distal bronchioles. Second, perinatal or immediate postnatal aspiration occurs during the first breaths, especially if vigorous crying or resuscitation generates high inspiratory pressures. The mechanical effects are significant. Meconium's thickness and particulate nature cause ball valve obstruction. Air enters alveoli during inspiration but cannot escape efficiently during exhalation. This produces hyperinflation of some regions, while others collapse atelectasis, creating heterogeneous ventilation. The resulting overdistension in open areas can rupture alveoli, leading to air leaks such as pneumothorax or pneumomediastinum. Simultaneously, meconium acts as a chemical irritant, inducing local inflammation. neutrophils and macrophages migrate to the airways, releasing proteolytic enzymes and cytokines, which damage alveolar epithelium. Surfactant function is impaired both by direct inhibition from bile salts and by inflammatory mediators, further reducing alveolar stability and compliance. The combination of airway obstruction, chemical injury, and surfactant inactivation creates ventilation-perfusion mismatch, leading to hypoxemia. In severe cases, pulmonary vascular resistance rises due to hypoxia and acidosis, promoting right-to-left shunting through the fetal channels and contributing to persistent pulmonary hypertension of the newborn. Mechanical obstruction in MAS begins when meconium physically blocks small airways. The thick, viscous, and particulate nature of meconium creates a ball valve effect, allowing air to enter alveoli during inspiration but preventing full exhalation. This leads to regional hyperinflation in some lung areas, while adjacent alveoli collapse, atelectasis, creating uneven ventilation. Hyperinflated regions increase intrathoracic pressure, reducing venous return and increasing the work of breathing. Overdistended alveoli are prone to rupture, which can cause air leaks such as pneumothorax, pneumomediastinum, or pulmonary interstitial emphysema. Small airway obstruction also traps secretions and thick fluid, worsening ventilation-perfusion mismatch. The result is hypoxemia and hypercapnia, with some alveoli underventilated and others overdistended, placing the infant at risk for respiratory failure. Chemical pneumonitis in MAS occurs when aspirated meconium contacts the pulmonary epithelium, triggering a robust inflammatory response. Bile salts, enzymes, and particulate matter directly irritate alveolar and airway lining cells, causing epithelial injury, edema, and increased capillary permeability. Inflammatory mediators recruit neutrophils and macrophages, which release proteolytic enzymes and cytokines, further damaging the alveoli and small airways. This inflammation increases airway resistance and contributes to alveolar collapse, reducing functional residual capacity. Surfactant is also inactivated by both the chemical components and the inflammatory process, lowering lung compliance and increasing the pressure required to ventilate alveoli. The combination of obstruction, inflammation, and surfactant inactivation results in ventilation-perfusion mismatch, hypoxemia, and hypercapnia. Surfactant dysfunction in MAS is both a direct and indirect consequence of aspiration. Meconium contains bile salts, fatty acids, and enzymes that directly inactivate surfactant, disrupting its ability to reduce alveolar surface tension. Indirectly, the inflammatory response triggered by chemical pneumonitis further degrades surfactant proteins and lipids, impairing their secretion and recycling by type 2 alveolar cells. The loss of surfactant function increases alveolar instability, particularly in smaller airways, leading to atelectasis, poor compliance, and patchy lung collapse. This contributes to the heterogeneous ventilation pattern seen in MAS, where some alveoli are overdistended while others remain collapsed. As alveolar collapse progresses, ventilation-perfusion mismatch worsens, driving hypoxemia and hypercapnia. The increased work of breathing can precipitate respiratory fatigue, and in severe cases, elevated pulmonary vascular resistance contributes to persistent pulmonary hypertension of the newborn. Risk factors for MAS can be divided into fetal and delivery-related contributors. Fetal factors include post-term gestation, which increases the likelihood of meconium passage due to a mature enteric nervous system and higher baseline meconium load. Fetal stressors, such as chronic hypoxia from cord compression, placental insufficiency, or intrauterine infection, stimulate vagal activity and increase the chance of in utero meconium passage. Delivery-related factors also increase risk. Complicated labor with prolonged or difficult delivery, non-reassuring fetal heart rate patterns, and episodes of fetal gasping during labor can draw meconium into the airways before or during birth. Instrument-assisted deliveries or rapid changes in intrathoracic pressure may exacerbate aspiration risk. Understanding these risk factors allows clinicians to anticipate MAS, implement appropriate delivery room precautions, and monitor high-risk infants closely in the immediate neonatal period. Maternal risk factors for MAS include maternal diabetes, which can delay surfactant maturation, and hypertensive disorders that may compromise placental blood flow. Maternal drug use, such as opioids or other agents that depress fetal respiratory drive, can contribute to fetal gasping and aspiration. Prolonged rupture of membranes or maternal infection increases the risk of fetal stress and hypoxia. Neonatal risk factors include male sex, which is associated with delayed surfactant production, and post-mature or large for gestational age infants, who have increased intestinal meconium load. Infants with perinatal asphyxia or low APGAR scores are more likely to gasp and aspirate meconium during delivery. The interplay of maternal and neonatal factors identifies infants at highest risk, allowing the team to anticipate delivery room needs, plan for early respiratory support, and implement careful monitoring strategies. Infants with MAS develop respiratory distress at birth or within the first few hours because aspirated meconium obstructs small airways and reduces alveolar ventilation. Tachypnea occurs as the infant attempts to increase minute ventilation to compensate for hypoxemia. Grunting is a result of partial glottic closure during exhalation, which maintains end expiratory pressure and helps prevent alveolar collapse. Retractions and nasal flaring reflect increased work of breathing as the compliant chest wall collapses inward during inspiration. Barrel chest develops as a consequence of regional hyperinflation from the ball valve effect of partial airway obstruction. Meconium-stained skin and umbilical cord indicate prenatal exposure, signaling that obstruction and chemical irritation may have already begun. Breath sounds are coarse, with rales and raunchy because some alveoli remain collapsed while others are overinflated, producing uneven ventilation and turbulent airflow. These findings connect directly to the underlying pathophysiology of airway obstruction and early inflammation in MAS. Severe MAS presents with hypoxemia that is refractory to supplemental oxygen due to extensive airway obstruction, alveolar collapse, and surfactant inactivation. Hypercapnia and acidosis develop as alveolar ventilation is impaired and CO2 clearance is reduced. Complications arise from the combination of obstruction, inflammation, and overdistension. Air leaks such as pneumothorax, pneumomediastinum, and pulmonary interstitial emphysema occur when alveoli rupture under high pressures. Persistent pulmonary hypertension of the newborn can develop from hypoxia and acidosis, sustaining right-to-left shunting and further worsening oxygenation. Infants with severe disease often require mechanical ventilation and, in refractory cases, extracorporeal membrane oxygenation. The first step in evaluating MAS is clinical recognition. You combine evidence of meconium-stained amniotic fluid exposure, respiratory distress, and chest radiograph findings to establish suspicion. Chest radiography provides key information. Expect patchy or asymmetric infiltrates, hyperinflated regions, and flattened diaphragms. Air leaks are common due to overdistended alveoli from partial airway obstruction. Arterial blood gases often show hypoxemia, sometimes accompanied by hypercapnia and mixed acidosis, reflecting impaired alveolar ventilation. A sepsis evaluation is recommended, including blood cultures and complete blood count, with tracheal aspirate culture considered if intubation is performed. This ensures that infection is not contributing to or mimicking the respiratory distress. In evaluating a newborn with MAS, the starting point is the clinical context. A history of meconium-stained amniotic fluid combined with respiratory distress immediately raises suspicion. Chest radiography provides critical information. Early in the course, you may see streaky perihilar opacities, which can be confused with transient tachypnea of the newborn. As the disease progresses, patchy alveolar infiltrates appear, often with overinflation of some regions and collapse of others. In severe cases, the lungs may appear diffusely opacified, resembling RDS, sometimes accompanied by small pleural effusions, flattened diaphragms, or air leaks. Arterial blood gas analysis typically demonstrates hypoxemia with hypercapnia and mixed acidosis in moderate to severe cases. This reflects impaired ventilation from airway obstruction, alveolar collapse, and surfactant dysfunction. Additional evaluations include blood cultures and complete blood count to rule out concurrent infection, and in some centers, tracheal aspirate cultures if intubation has been performed. Lung ultrasound may reveal coalescent B lines, irregular pleural lines, or a double lung point. helping differentiate MAS from TTN or RDS. Lung ultrasound can be a valuable adjunct in MAS. Findings often include compact or coalescent B lines, which indicate alveolar interstitial edema or obstruction. The pleural line may appear irregular, reflecting inflammation or atelectasis at the subpleural level. A characteristic feature is the double lung point, where the upper lung regions remain aerated while the lower regions are consolidated. This helps differentiate MAS from transient tachypnea of the newborn, TTN or RDS, which typically show more uniform lung involvement. Lung ultrasound is particularly useful in ventilated infants, as it provides real-time assessment of consolidation, aeration, and air trapping, guiding ongoing respiratory management without repeated radiation exposure. MAS must be distinguished from other causes of neonatal respiratory distress. TTN usually improves rapidly and lacks coarse breath sounds, while respiratory distress syndrome is more common in preterm infants, with low lung volumes and diffuse ground glass opacities on imaging. Pneumonia can mimic MAS early on, so empiric antibiotics may be required until cultures are available. Cyanotic congenital heart disease or persistent pulmonary hypertension presents with hypoxemia refractory to oxygen, often confirmed by echocardiography. Congenital diaphragmatic hernia is identified by a scaphoid abdomen, bowel loops in the chest on imaging, and immediate respiratory compromise. Careful assessment of history, clinical signs, and imaging findings allows clinicians to differentiate MAS from these conditions, ensuring appropriate and timely management. Management begins with NRP-guided resuscitation, prioritizing effective ventilation while avoiding interventions that can worsen hypoxemia or PPHN. Routine intrapartum suctioning is no longer recommended for infants exposed to meconium, and vigorous infants do not require tracheal suctioning. For non-vigorous infants, tracheal suctioning may be considered if airway obstruction prevents adequate positive pressure ventilation. Endotracheal suctioning is reserved for cases where meconium physically blocks the airway and interferes with ventilation. Avoiding hyperstimulation is critical, as excessive handling or vigorous interventions can exacerbate hypoxemia, increase pulmonary vascular resistance, and worsen the newborn's condition. Oxygen therapy is adjusted to maintain oxygen saturation in the target range of 90 to 95%. This helps improve tissue oxygen delivery while avoiding excess oxygen, which can worsen oxidative injury in the lungs. A neutral thermal environment is maintained to reduce metabolic demand and oxygen consumption, supporting the infant's compromised respiratory system. Handling is kept to a minimum, and care is gentle to avoid increases in pulmonary vascular resistance. In MAS, alveolar collapse and inflammation already elevate pulmonary pressures. Stress or stimulation can worsen hypoxemia and contribute to persistent pulmonary hypertension of the newborn. Glucose levels are monitored and fluids provided as needed to support energy requirements for the increased work of breathing. Empiric antibiotics are administered until infection is excluded, since sepsis can mimic MAS or occur concurrently, and early treatment prevents additional pulmonary compromise. Initial non-invasive support for MAS focuses on correcting hypoxemia while minimizing lung injury. Supplemental oxygen is delivered via hood, mask, or low-flow nasal cannula. The goal is to increase oxygen delivery to tissues without applying high pressures that could overdistend alveoli or worsen existing air leaks. CPAP recruits collapsed alveoli by maintaining positive pressure in the airways throughout the respiratory cycle. This improves functional residual capacity and oxygenation. In MAS, partial airway obstruction from meconium can create a ball valve effect, allowing air in but preventing full exhalation. CPAP can exacerbate regional hyperinflation, so careful monitoring of chest expansion, respiratory rate, and carbon dioxide levels is essential. Signs of air leak, such as subcutaneous emphysema or sudden desaturation, must be watched closely. High-flow nasal cannula delivers heated, humidified gas at flows sufficient to provide low-level positive airway pressure. It is easier to tolerate than CPAP and allows better access to the infant. HFNC can wash out carbon dioxide from the upper airway and support ventilation, but its effectiveness is variable in MAS, particularly in severe disease. The risk of air trapping and worsening hyperinflation remains if the flow generates unmonitored pressure in obstructed airways. Close observation of respiratory effort, oxygenation, and ventilation guides adjustments in flow, oxygen concentration, and interface choice. The goal is to stabilize gas exchange while minimizing the risk of further alveolar injury or pneumothorax. Invasive ventilation is indicated for infants with MAS who remain hypoxemic or hypercapnic despite optimal non-invasive support. Conventional mechanical ventilation is commonly used, with attention to volume-targeted modes to minimize barotrauma. Careful selection of peak inspiratory pressure is crucial to prevent alveolar overdistension, particularly in lungs affected by ball valve obstruction from meconium. Adequate expiratory time must be ensured to allow trapped air to escape, reducing the risk of air leaks, hyperinflation, and pulmonary interstitial emphysema. High-frequency ventilation may be considered for infants with refractory hypercapnia, severe air leaks, or persistent hypoxemia. This mode allows lower tidal volumes at rapid rates, limiting volutrauma while maintaining oxygenation and carbon dioxide clearance. Invasive support is closely guided by continuous monitoring of oxygenation, carbon dioxide levels, and ventilator graphics, allowing adjustments to pressures, rates, and inspiratory times to optimize ventilation perfusion matching and reduce further lung injury. In MAS, surfactant is often inactivated by aspirated meconium, which disrupts both the phospholipid and protein components. This decreases alveolar stability, reduces compliance, and worsens ventilation perfusion mismatch. Exogenous surfactant is administered to restore alveolar surface tension, improve lung compliance, and recruit collapsed alveoli. This intervention can improve oxygenation and reduce the need for high ventilator pressures, limiting further barotrauma. Delivery is typically via intratracheal bolus, and some centers investigate surfactant lavage, which may help remove meconium from the airways while delivering surfactant. Repeat doses are often required if severe MAS persists or compliance remains poor. Adjunctive therapies in MAS address complications, such as persistent pulmonary hypertension, agitation, and infection risk. Inhaled nitric oxide is used in infants with severe MAS, complicated by pulmonary hypertension, to dilate pulmonary arteries, lower pulmonary vascular resistance, and reduce right-to-left shunting. Sedation and analgesia are important for ventilated infants, as agitation increases oxygen demand and work of breathing. Empiric antibiotics are administered until infection is excluded, since pneumonia can coexist with MAS or mimic its presentation. For refractory hypoxemia despite optimal support, extracorporeal membrane oxygenation may be required as a rescue therapy to maintain oxygenation and allow lung recovery. MAS can produce severe acute complications because the combination of airway obstruction, chemical pneumonitis, and surfactant dysfunction creates uneven ventilation and alveolar overdistension. Air leaks, including pneumothorax, pneumomediastinum, and pulmonary interstitial emphysema, occur when overinflated alveoli rupture under high inspiratory pressures or ball valve obstruction. This further reduces effective ventilation and can rapidly worsen hypoxemia. Persistent pulmonary hypertension of the newborn develops when hypoxia and acidosis elevate pulmonary vascular resistance. Right-to-left shunting through the ductus arteriosus or foramen ovale sustains systemic hypoxemia, complicating oxygen therapy and sometimes necessitating inhaled nitric oxide or ECMO. Chronic consequences arise from prolonged mechanical ventilation, repeated alveolar injury, and ongoing inflammation. Infants are at risk for bronchopulmonary dysplasia, and airway remodeling may lead to recurrent wheezing or asthma during childhood. Mortality is influenced by disease severity and comorbidities. Infants with severe PPHN or associated anomalies have higher mortality rates, while most survivors eventually recover lung function. Neurodevelopmental impairment can occur in infants who experienced severe hypoxemia or systemic compromise during the acute phase, reflecting the interplay between oxygenation failure and multi-organ stress. Meconium Aspiration Syndrome primarily affects term and post-term infants exposed to meconium-stained amniotic fluid, with approximately 2 to 10% developing MAS. Disease severity ranges from mild tachypnea to severe respiratory failure with persistent pulmonary hypertension. Pathophysiology is defined by a triad of mechanical obstruction, chemical pneumonitis, and surfactant inactivation, which produces ventilation-perfusion mismatch, hyperinflation, atelectasis, and air leaks. In severe cases, elevated pulmonary vascular resistance sustains right-to-left shunting, worsening hypoxemia. Risk factors include post-term delivery, fetal distress, thick meconium, intrauterine growth restriction, oligohydramnios, and maternal conditions such as hypertension or diabetes. Male sex and neurologic depression at birth further increase susceptibility. Clinical presentation varies from coarse breath sounds, barrel chest, and hypoxemia to severe cases with air leaks, refractory oxygenation, and PPHN. Diagnostic evaluation relies on history of meconium exposure, physical findings, chest radiograph, and lung ultrasound, with blood gas and sepsis workup as indicated. Management emphasizes supportive care, including oxygen, CPAP, or non-invasive ventilation, with escalation to mechanical ventilation or high-frequency ventilation as needed. Exogenous surfactant may be administered for severe disease, and inhaled nitric oxide, or ECMO, is reserved for PPHN or refractory hypoxemia. Outcomes are generally favorable, though severe MAS can result in air leaks, chronic lung disease, recurrent wheezing or asthma, and neurodevelopmental sequelae.